You can begin.
Okay. Good afternoon. I would like to thank our colleagues in the Egyptian Society of Ophthalmology, our Egyptian doctors, always colleagues and partners in many things, in Oman and in the conferences. And we welcome them now as International Society guests, as brothers actually. And we thank them for that. They agreed that they share with us our conference. And all what I can say to them, the conference, their conference, and they are welcome. And thank you very much for this highly esteemed lectures. We'll start with Dr. Ibrahim Al-Adawi. He will talk about strabismus patients evaluation, history taking. So please welcome Dr. Ibrahim.
Good evening, everybody. Thank you very much for the Romanian Ophthalmological Society to be a part of this meeting. Today, we will discuss about one item in evaluation of a strabismus patient. As you know, the strabismus is a unique entity in ophthalmology. Each patient should be evaluated on an individual basis. The goal of evaluation is to establish the cause of strabismus, to assess the binocular sensory status, and to measure the deviation, as well as to diagnose whether there is amblyopia or not. How to evaluate the patient of strabismus? By three main items: history taking, which we'll discuss today, physical examination, as well as spatial test. And history taking, from the good history, you can reach the diagnosis of most of cases of strabismus. Even you may know the method of treatment. Even you may know just from the history the prognosis of this case. The item should be fulfilled in history taking: the onset and the character of strabismus. Is it constant or intermittent? Is it associated with face turn or head tilt? Is it congenital, acquired, or late acquired? Is it comitant or incomitant strabismus? You have to look to the family album, and this is very important item. You have to ask about diplopia, is it present or not, as well as the family history. Number one, and the most, to my mind, the most important question is the onset and the character of strabismus. If the strabismus starts very early, this means in the first 6 months of life, this means this is a congenital strabismus, either congenital esotropia or congenital exotropia. If the onset is so delayed to 2 to 3 years, this is hypermetropia, and this is a accommodative type of strabismus. And the management is just a glass. Sometimes there is a late onset comitant esotropia like that. If the esotropia starts very late, after the age of 10 years, suddenly after 10 years, this is not the age, this is not the usual age of strabismus. Then you have to suspect the central cause, and you have to manage to image this patient. Is it comitant, constant, or intermittent? What is the difference between constant strabismus and intermittent strabismus? Intermittence means there is some sort of binocularity. Sometimes the patient is orthotropic like that. Sometimes is exotropic. So intermittent strabismus means there is binocular, there is some binocularity, and there is a fusional potential, and this makes the prognosis much more better than constant strabismus. Is it associated with face turn or head tilt? Sometimes we see these cases. This is a case of head tilt to the right. This is a chin elevation due to null point nystagmus. This patient, very small child with typical head tilt of the superior oblique palsy, V pattern esotropia, null point nystagmus. This patient, when we straighten the head, there is hypertrophy of the left eye. This is a case of left superior oblique palsy, and this is after treatment, after surgery. Is it congenital, acquired, or late acquired? This patient, 18 years, come look to this date, 4 February 2007. Sudden onset of diplopia, limited abduction. This is a case of 6 nerve palsy, sudden 6 nerve palsy in a patient with 18 years old. When examined the funda, there is marked papilledema. This patient is imaged and referred to neurologist. This patient come after 1 week. Look to the date, 11 February 2007, with complete movement after taking the treatment. Also, the strabismus, is it comitant or incomitant? Comitance means there is free ocular motility. Incomitant means there is a restriction, either restricted or paralytic. This is a comitant esotropia after surgery. This is a comitant exotropia. This is a case of congenital third nerve palsy, as you see. In this is exotropia, hypotropia with ptosis, abduction, okay, limited adduction, limited depression, limited elevation. This is a classic case of congenital third nerve palsy. This is a case of with head tilt. When straightened the head, there is hypertrophy of the right eye. This is a case of fourth nerve palsy, superior oblique palsy, with inferior oblique overaction here. Also, there is a case right esotropia. Looking to the right, there is defective abduction. This is a case of 6 nerve palsy. This is a case of Duane retraction syndrome in the left eye with limited abduction, with widening of the palpebral fissure on abduction, with narrowing of the palpebral fissure on adduction together with upshoot. This is a case of thyroid eye disease with proptosis and contraction of the inferior rectus with hypotropia. To differentiate between restrictive and paralytic force abduction test, this is a positive force abduction test, and this is a negative one. Also, the family album, you have to look to this. This is very important. This patient come with this picture, no head tilt, with hypertropia on the left eye, moving to the right, to the left. All picture suspect this is a case of severe oblique palsy. Why there is no head tilt as usual in severe oblique palsy? I asked the mother, is he tilted his head before? She came with this photo. She said he is always tilting the head, but since 1 month he straightened the head and the strabismus appear. Sometimes the hypertropia increased so much, there is so it is out of proportion to be compensated with the head tilt. So the brain neglected this eye and the patient straightened his head. Like that picture. This is a case of neglected severe oblique palsy. Also, you have to ask about the trauma. This is a case of post-traumatic third nerve palsy with ptosis, exotropia, limited adduction, depression, and elevation. Also, you have to ask about diplopia. Diplopia is incompatible with life. Look to this straight. This is the usual appearance for everyone, normal. If the patient had diplopia, he see like that. This is impossible to cross this street. And after that, the physical examination, this is the item of the physical examination. We will not discuss it. But the first item in physical examination is the observation. During the history taking, during the period you take the history, you talk with the mother, with the father, or with the patient himself, if he's old enough, you have to observe the visual behavior of the patient. Is it seeing or not? The eye movement, is it free movement or not? You have to notice the alignment. The patient is orthotropic or ezo or exo, something like that. You have to know the fixation pattern, and you have to know or to see or to notice is there is any abnormal hair posture or not. From this is a multiple cases is phobia. This is a case of cross fixation. The patient cannot look straight, either look to the right or to the left. This is a retinal point nystagmus. This is an exotropia. This patient, this is the last slide. The patient, the mother and the daughter have left Duane syndrome, superior oblique palsy, Duane. This is the observation. Thank you very much.
Thank you, Dr. Ibrahim. And I think we'll leave the question for the end. I think better. Do you agree with me? I think better. So next, Dr. Ahmed Ghunaim is already.
السلام عليكم جميعا. السلام عليكم دكتور رشيد، دكتور محمود،
دكتور أحمد. أهلا وسهلا بك.
أهلا بك.
أهلا وسهلا. Welcome, and now Dr. Ahmed Ghunaim will talk about white cataract management. Please welcome, and looking forward to hear from you. يا دكتور أحمد؟
أنا بعمل شير أهو.
Not going?
طيب ممكن ناخد next speaker until I fix my presentation. دكتور حاتم عمار أنت جاهز؟
I'm Dr. Muhammad.
دكتور محمد خلي أنا
I'm helping Dr. Rashid in moderating this session as well. So
okay تمام. حضرتك بعد إذنك ممكن نبدأ دكتور حاتم until I fix my sharing screen.
Okay. Dr. Ahmed Assaf or
دكتور حاتم عمار.
Okay. Dr. Hatim Ammar.
I am ready if you want to me share my screen. But Dr. Assaf is not here.
So you will do it instead of him. Okay.
Okay. I'll start my presentation now.
Yes, please. Yes.
Okay.
Thanks.
1 minute, please. Okay. Good evening, everybody. Thanks to the Oman.
بفتح من الكمبيوتر ولا لازم انزلها على الدروب بوكس ولا ايه؟
لا ممكن تفتح من الكمبيوتر. Thanks for the invitation from the Egyptian Society of Ophthalmology and the Muscat Ophthalmological Society. I'm here to speak about a little bit bad subject in ophthalmology is management of rupture posterior capsule during phacoemulsification. Posterior capsule rupture and vitreous loss are inevitable complications which encountered in cataract surgery across all levels of surgical experience and in spite of technological advances to improve safety. Rate of PCR vary from 0.4 to 5% in large studies. Cataract surgeons must always be prepared to practice safe and effective intraoperative management strategies for capsule rupture. What are the complications of PCR? As all we see this long list of complications, all we know. What is the aim of management? To maintain capsular and zonal integrity, to protect the corneal endothelium, stabilize the residual lens materials in the anterior chamber whenever possible, and to prevent and manage vitreous prolapse and traction, strive for complete nuclear and cortical removal and appropriate IOL implantation if possible. Let's see this movie. Smooth phacoemulsification without any challenges. Capsulorhexis. Unfortunately, this case was posterior polar cataract and I missed it and did perfect hydrodelineation. Hydrodissection and hydrodilation. An excellent hydrodissection, as you see, and hydrodelineation. It is missed from me that it is posterior polar during the crowd of the day. When dealing with the cataract, as you will see, phacoemulsification, routine case. I don't know that the posterior capsule is ruptured, but now, as you will see here, there is a very large opening will appear in this area. It's a very big rupture by the mistake. The key, never run away. Keep the irrigation maintained, inject dispersive OVD. My preferred one is viscose with no financial interest. If you don't have, you can use methyl cellulose or even here, but dispersive is better. Now, you must clean any vitreous present in the anterior chamber, remove, do vitrectomy well, make use of the cutter as IA. Here, I make use of machine as IA cut to remove the cortex. You must clean cortex well. Clean any vitreous prolapse, clean cortex as you need. Take your time, rotate your hand, clean any available lens matter present. Alternate between IA cut and cut IA. When you aspirate lens matter, you must do IA cut. But when you remove vitreous, you must cut IA. Always the anterior chamber must be pressurized. Keep it irrigation maintained, then inject dispersive OVD even after you removed most of the anterior vitreous. After blood, now evaluate the tear. Very large tear, you can't convert into capsulorhexis, but there is anterior capsulorhexis edge which is well formed. It can help you to implant multi-piece, 3-piece IOL in the sulcus. But please take your time. Avoid injecting it into the posterior segment. Position it. Sometimes we inject it in the front of the iris and reposition. But as you can control your injector, you can inject it directly into the sulcus. Rotate it. Now it is well positioned in place. This case usually takes longer time than any routine case, but if you managed well, you can end it safely. Now, optic capture is a must in this case to ensure stability of the IOL and prevent UGH syndrome. As you make it, it is now ensured this is the edge of the anterior rhexis in front of the optic of the IOL, narrow the pupil after doing the capture, and you can finish the case safely without any challenges, but always pressurized eyeball. Sometimes the rules are don't panic. Take your time, never panic, never run away. Always keep the anterior chamber pressurized, maintain the irrigation or pressurized by OVD, never run away, and maintain formed AC, dispersive OVD, and safety first. Sometimes you make rupture posterior capsule. This is a brown to black cataract. It is everyday practice in Upper Egypt, where the area where I do my practice. After doing divide and conquer technique, fracture the nucleus, 2 halves. Now I want to emulsify for the first half. I feel everything is okay, no problem. A little bit hard, but no problem. But now, what's going here? Here there is a large rupture of the posterior capsule, as you see. Keep irrigation maintained. Never run away. Take your time and take deep breath. Inject dispersive OVD. Take time to allow your assistant to find the OVD. Don't shout over him. Don't make much noise in the operative theater. It is my mistake. I ruptured the posterior capsule. Inject dispersive. The ideal is viscose by name with no financial interest. Now evaluate the size of the tear. Here there is a very large tear, nearly half of the capsule in the petal area, in the area in front of me. Now it is impossible to continue fecal emulsification with the routine rule. So I will stabilize the half of the nucleus in front of the iris, remove it from the capsular bag to be supported by your eyes, positioned inside. It is half of the nucleus, but no problem. After injection of OVD, you can put it in the anterior chamber. I decided here to shift to the technique of what's called the scaffold IOL, which is introduced by our Indian famous surgeon Ammar Agrawal. Implanting multi-piece IOL in the anterior chamber with the haptic in front of the iris to use it as a scaffold to separate between the anterior and posterior segment. So here, the IOL make artificial posterior capsule. I am protecting the nucleus from being displaced into the posterior segment, ensure well position of the IOL in front of the iris. Now, you can do fecal emulsification, but with a little bit different parameters. Fluidics must be low, ultrasound low, take your time slowly, inject dispersive OVD many times. You must every now and then inject viscose to protect the cornea or methyl cellulose. Take time. This is sure edited movie. It takes much longer time than this, but you can finish very hard nucleus and keep the nucleus fragment being lost in the posterior segment. Now I will manipulate the IOLT position in front of the capsulorhexis in the sulcus, rotate the second haptic, the trailing one. Remember, there is a lens matter here in this area. It is not permitted to leave any lens or cortical matter at all to prevent the reaction, post-operative uveitis. Now I use the cutter, making use of the parameters of the phaco machine to use it as cutting to remove any vitreous strands, and IA cut to aspirate nucleus, cortical matter or lens matter. As you see here, I am cutting. Now I am going to aspirate cortex as IA. So no cutting here. It is IA cut. It is a different mode present in most of phaco machines. Use irrigation aspiration at the first and cutter when there is vitreous strands in your hands. So clean the anterior chamber, remove any lens matter, don't run away, always pressurize the eyeball. Hydration while irrigation is maintained. As you see, you can finish the case safely. I inject air here to photograph the eye in the second day post-operative. As you see, cornea is clear, pupil is rounded, everything is okay. Scaffold technique is a real, valuable technique in these conditions if you managed it well. When time is off, please inform me. Rupture capsule can occur at any time, sometimes during irrigation aspiration. This is a case of posterior polar cataract. If you try to polish a posterior polar cataract, as here, after removing it, I find posterior capsule is opaque, so I try to polish it. Take care. If you polish the posterior capsule in posterior polar cataract, you may rupture the posterior capsule. Now, as you see, there is a rupture posterior capsule in this area. The same rules. Don't run away, dispersive OVD, and now my aim is to convert this tear into posterior capsulorhexis. As you will see here, I will convert it into posterior capsulorhexis, taking time, so you can inject OVD, and here, this is a rounded posterior capsulorhexis, as you see the mouse, and you can implant single piece IOL here in the bag, without need to implant multi-piece. She's young, and I want to give her a spheric IOL, as you see, so you can make use of the small tear in the posterior capsule to convert it into a posterior capsulorhexis. Anytime after nuclear division, sometimes like this, after dividing the nucleus and removing many quadrants, you'll find rupture posterior capsule, inject dispersive OVD, remove by visco-expression all particles. There is a large opening in the center. Visco-expression to deliver any small particles of the nucleus outside slowly. Now, this is the tear, and the posterior capsule is anterior rhexis is intact. You can implant in this condition multi-piece IOL in the sulcus, rotation, optic capture, and you can finish the case safely. Rupture posterior capsule occur at any time. So to take home message, never be panic, never run away, maintain formed AC, dispersive OVD, safety first, and thank you. You can do it very well. Thank you. I don't hear you. Dr. Muhammad, you can unmute yourself, please.
Thank you,
Any
Dr.
question?
Informative lecture. Now moving to Dr. Ahmed Ghunim. Are you ready? Dr. Ahmed? So moving to the next lecture. Hisham Hasbi. Dr. Ahmed Ghunim, do you hear me?
Unmute yourself, Dr. Ahmed.
Dr. Ahmed, are you ready for the talk?
Yes, I'm ready.
Please.
Okay. You can hear me?
Yes, yes. Share your slide, please.
Is my share? I'm shared now?
Not yet. Down the screen, share screen.
Yes.
Sir, at the bottom, can you see an option in green that says share screen? Hello, doctor, am I audible?
Dr. Ahmed,
Is it okay now?
still not
No,
yet.
sir, we can't see your screen. Sir, at the bottom, there's an option in green that says share screen.
Yes, I'm doing it, but I don't think that I'm
Yeah,
shared.
so no, a pop-up box will appear. On that pop-up box, you'll have to select the screen option and then again click on share.
Okay.
Can you do that, please?
Yes. Is it okay now?
Still?
No, sir, we still don't have your screen.
Okay, we can.
What does it say?
Dr. Hisham Hasbi can start.
Yeah.
Okay,
Okay.
right.
Hisham, Dr. Hisham.
Yes, I'm here.
Shukran. Thanks, Dr. Hatim, for this nice presentation. And we'll continue with Dr. Hisham Hasbi. Hisham, you can hear me.
Yes.
It looks he doesn't hear us. Dr. Hisham.
ايوه انا هنا. حضرتك سامعني؟
Dr. Hisham.
Yes.
Hello. Do you hear us?
Yes, sir. That wasn't clear. Can you hear me?
Can you start your presentation, please?
Sure. Okay.
Now, share your slide, please. Yeah. Yeah.
Okay. It's such a pleasure to be here at Muscat International Ophthalmology Conference among all these distinguished guest speakers and professors of ophthalmology. And it's a great honor for me to be participating in the Egyptian Society of Ophthalmology session. Today, my presentation is going to discuss some of the challenges associated with DALC surgery. We all know the classic 5 layers of the cornea and the newly described 6th layer that was named after Professor Doa of UK. Doa's layer is actually a condensation of deep stromal collagen in front of Descemet's membrane. DALC is basically suitable in any keratoplasty candidate whenever the endo layer is healthy. DALC has many advantages over PKB: no endo rejection, shorter course of steroids, earlier removal of sutures, but no refractive advantage. Challenges may be met with DALC either intraoperatively or postoperatively. The first challenge with DALC is failure to induce the big bubble despite repeated injection of air into deep stroma. Simply, you can switch to a cut-down DALC where you remove deep stromal as a layer by layer with the aid of hydration. As you can see in this video, I am taking out the deep stroma layer by layer, and I hydrate whenever I have to. On the right side, you may notice some stromal shreds in the early postoperative OCT, but within few days, Descemet's membrane has become totally attached, and the endothelials started or succeeded to clear out the graft. Second challenge is when you have a simultaneous type 1 and type 2 bubbles. In this situation, you may sacrifice Doa's layer and keep Descemet's membrane of the recipient only. So here we have opened the deep stroma. We have a Doa's layer in front of us. And now we are making a snip in Doa's layer, and we have the Descemet membrane lying beneath. To make sure, we're going to inject some air into the anterior chamber, and it will not leak. This is a proof that Descemet's membrane is still intact. Challenge number 3 is Descemet's membrane perforation. Well, it depends. If the Descemet membrane tear is small and peripheral, you may continue with DALC. But if the tear is large and central, you may have to convert to a PKB. Challenge number 4, remaining visco at the interface. We use visco during deep stromal dissection to replace the air before excision of the deep stroma. And it has to be washed out thoroughly before placement of the graft to avoid Descemet's membrane non-attachment. Challenge number 5 is related to removal of donor Descemet's membrane and endo during graft preparation. And this process is more difficult in grafts taken from younger donors. So it might not be a very good idea if you're starting your DALC to use a donor coming from younger age group. However, you may not be able to do a smooth stripping of Descemet membrane. In this situation, you may do a piecemeal removal or simply rub the endothelial cells dead. An interesting paper published in Cornea Journal in 2014 found a non-significant difference in Descemet's membrane non-attachment rate after DALC, comparing grafts with Descemet membrane on versus those grafts with Descemet membrane off. As you can see in this DALC patient, the donor graft had a Descemet membrane on. Unfortunately, 1 month after surgery, and still Descemet membrane has not attached, giving rise to a double anterior chamber. 3 months after surgery, the host Descemet's membrane started to fibrose, shortening the length of arc and pulling Descemet's membrane further backwards away from the graft. It's now impossible to attach. In the meanwhile, the donor endothelials that are still alive, they are functioning and keeping the graft thin and clear. To solve this situation, the patient had a excision to open the Descemet's membrane of the recipient, thus transforming the case from a DALC into a PKB without going back to the OR. The sixth and last challenge is which gas to use for anterior chamber bubbling if Descemet membrane hasn't attached in 2 weeks after surgery. And you can see that we can use either an air bubble that will remain 2 to 3 days before total absorption, or better to use a 12% SF6 bubble. This is a non-expansile concentration of the SF6 to let the bubble stay longer, on average 10 to 14 days into the anterior chamber, till you make sure that Descemet membrane has become totally attached. This is the first example before and after anterior chamber bubbling, and see how the Descemet membrane became fully attached and the cloudy cornea has become crystal clear. Another example for anterior chamber bubbling with similar findings. So my take-home message is, although DALC is a stressful procedure for me as a cornea surgeon, it has saved a number of patients who are either more susceptible for rejection or non-compliant with long-term steroid treatment, topical form, and sometimes we have to use systemic as well. So I will attempt DALC whenever possible in keratoplasty candidates, provided that the corneal endo is normal. And remember that most of the intra and post-operative challenges associated with DALC can be managed, and whenever needed, conversion to PKB is straightforward. Thank you very much.
Thank you very much, Dr. Hisham Hasbi. It was an informative lecture. Now back again to Dr. Ahmed. Are you ready? Dr. Ahmed Ghanem. Dr. Ahmed Ghanem, can you hear me, please? Are you ready for your lecture?
Yeah, I'm ready for that. Is it okay now?
Still not yet.
Sir, at the bottom, there's a green option.
Yeah, I do it, but I don't know what's happened.
No, if you click on that, a pop-up box will appear. On the pop-up box, you'll have to click on screen and then again click on share.
دكتور احمد المشكله واقفه فين معاك؟
حاتم مش عارف يعني لما بعمل افتح السكرين بتاعي بيطلب دروب بوكس وبيطلب حاجات تانية.
تبقى هي البرزنتيشن مش على الكمبيوتر يعني؟
لا، موجودة على الكمبيوتر. ما انا بفتحها، بس انت بتقول انها مش واضحة. انا فاتحها دلوقتي.
طب شير سكرين كده، خليها شير، هيظهر لك البوكس الصغير ده. شير كل السكرين واعمل قدامنا بس.
Can share your desktop screen.
بالظبط، شير كل سكرين. اختار العلامه الرئيسيه اللي فوق، اول واحده على الشمال، ودوس على دي اوكي.
في عندي شير،
ايوه،
دروب بوكس وجوجل
لا.
درايف وبوكس. ما فيش عندي في ادفانسد portion of screen.
Sir, you don't have to go to the portion of screen. On the basic option, there's a
desktop basic.
first
ايوه
option. Yeah, below the basic option, you can see
desktop
option.
بس
good.
حاليا شير.
Yes,
كده
yes,
اوكي.
perfect.
Yes, thank you.
Okay.
Perfect.
Sorry for this disturbance. I am greetings from Egypt for our colleagues and Oman, Dr. Shidi and for Dr. Hatem and Dr. Assaf, Dr. Mu'taz, Dr. Mahmoud, Dr. Ibrahim. I'm talking today about management of white cataract. First of all, we have to think about that anterior capsulotomy dictates how rest of the procedure will go. I think this is one of the most important step to have to continue your case for cataract, for right cataract. Like in this case, we are afraid about what we have and what we call Argentine flag sign. So maybe in while I'm working, if I continue my rexes and the white cataract, so the most difficult part of the procedure is over. Like in this case, you can just puncture the capsule, and you find that it's running away, and it makes the case more or less difficult. There is no 100-degree sure about that you don't have an Argentine flag sign, but you have to understand what's going about, what's the meaning of or types of white cataract we have. If you have no liquefaction or no fluid and no risk, this is like in this case, we can do the rexes even under saline, because this type there is no fluids, no liquefied material, so the age of the rexes is floating in the anterior chamber, then you can continue your case. And we have to think, or we have to know that the rexes or the capsule age is very strong until you didn't affect its integrity. So like here, we can feel the click I'm doing to just enlarge how much force I have to try to just click, to just widen we can see it here, to widen the rexes. You can see this click. That means how strong is the rexes. So the third type is the milky white. So we spoke about the first type and the third type. So the small nucleus with a free pathway, we don't have a problem. In this case, we don't have to do hydrodissection, or even you just having a normal hydration. So you can inverse your hand. You do irrigation aspiration before phaco, because you're removing the cortical material, not to have dusting in the anterior chamber. Then you can use your second hand, because you just lost your support. So you have to use, because you will find that the nucleus is moving below your hand. So you have to fix it by the other hand. And the third type is the pearly white, which is intubescent cataract with the more some liquefaction, which is a more risky. Like here, because if you just, there is two level of fluids just behind the nucleus and one in the front of the nucleus. If we can find here, if you just puncture the anterior capsule, that you'll find that this nucleus is pushing forward. So that's exactly what happened. You have a liquefied cortical material, swollen lens, weak zonule, or positive high pressure of the vitreous. So this is the force comes forward to enlarge your rexes. So my opinion is to do like in this case, I'm trying to do the spiral rexes, like here, just to be sure first that you have a big bubble or only one bubble in the anterior chamber. Here, you have to remove the aqueous, like in this case. You have to remove all the aqueous in the anterior chamber, so to be sure that there is you have a big bubble, so you can continue the rexes. We can do what we call a spiral rexes, like here. You can do it very small, like in cutting an orange. So if you feel that you have an extension rexes, you can move your hand to the center, then you can keep your rexes and enlarge it. be careful that sometimes the edge of the rexus can roll around your rexus forceps, so be careful about that. Then until you finish, you can take it out and you can get the optimal side of rexus you need. Even in this case, exactly like the other case, I just stain, and then I don't recommend to wash the stain and just inject your viscoelastic. Injecting the viscoelastic after injecting the stains keeps the endothelium untouched by the stain, and even you have to use a lot of stain to stain it, and you can continue your spiral rexus like here. Sometimes you can do 2 steps or even 3 steps rexus, spiral rexus, like in this case. This is the first stage, first step, then second step. And even if you find that you have an extension, you just inject more and more viscoelastic, like in here, because this is the most, I mean, easier way to catch your rexus. You can enlarge the wound if you're using 2.2 to give a good a good space to use your rexus if you don't have the crocodile rexus. We can also face a late Argentine flag sign, like in this case we have some sort of capsular fibrosis on the anterior capsule. So this part or this area is one of the weakest part in the anterior capsule. So while doing or trying to rotate the lens like here, you might find that you have a late Argentine flag sign even if you finished your rexus. Like in this case, you can see the extension. For me, I don't recommend to complete a case in like this. Anyway, what we're gonna do if you just lost if you face this? So we spoke about how to prevent the Argentine flag sign, but what will you do if it happens? If it happens, you have to just take some of the fluid from to decrease the pressure in the capsular bag, then try to extend the rexus so you don't have the force in one direction, and try to complete it, and you have 180 degrees apart of each other. So the power while you're walking is not condensed on one space or one area. It's just divided in 2 spaces. And at the beginning, I like to have a suction to take the nucleus outside a little bit. So I give an opportunity to some fluids get behind, and I can continue the case. But no matter if for the beginners, if you lost your rexus in a case of white cataract, you can convert, or if you are reminded about the technique, so it's better not to divide, complete division of the 2 halves, because you might face one of these halves dropping down. So it's better to still leaving them attached to each other, not totally separating them, and you can continue your case like here. And this is not an ideal case, but this is one way how to manage in such case, which is a grade 3 white cataract, and also you are not afraid to have a posterior rexus extension. And this is the final view of the case. What about if you have a small pupil? You have to use your other hand, even if you don't have other methods to dilate the pupil. Sometimes what we call is if you divide a case, if you make a division in this case, and you find that the 2 halves is not coming back to each other, so you have to think about that you have a problem in the posterior rexus, on the posterior capsule. Maybe Dr. Hatem have spoken about this part, but my opinion is doing posterior assisted levitation. You can see my other hand is pushing the other half to get it out, and then I can make a physical expression of this half, because if you find this signs, that means that you have a ruptured posterior capsule, so you don't have to put your phaco handpiece no more, and I can do physical expression after widening a little bit the wound, and I can continue the case with maybe 1 stitch or something like that, or you can put a 3-piece IOL sulcus with an optic capture. Finally, we all face with the high machines and high tech that we can find the remaining part of the nucleus in the white cataract. This is a norm. I mean, it's obvious now that we can see it after the operation. So this case came to me in the 2nd day, and I found this part of the lens. So when I go back for the lens, and I find that I didn't catch it by my phaco handpiece, it goes behind the iris. You can see it here with a slow motion again. You can see this part here now. It's just pushed by the repelling force of the phaco handpiece, and that's why I find it. So it's better for you to do what we call wash or IA of the lower part or the under part between the anterior rexus and the back of the iris, so you don't miss something like this particle, because you might find that you have some corneal edema or some cortical matter in the anterior chamber. Finally, don't forget that with white cataract, you can face something like that. Always forget, even with the good techniques you might find. So you have to know how to deal maybe in next session. Thank you very much. سبيكر سامعني يا هشام؟
تمام
هشام.
ايوه باشا تمام.
دكتور محمود.
Dr. Ahmed Ghunem, thank you very much for sharing your experience regarding hypermature cataract. Now moving to Dr. he will give a talk about corneal biomechanics and target IOP.
Yes, hello everybody. I'm so glad to participate in such an international event. I will talk about corneal hysteresis and corneal resistance factor in determining target intraocular pressure in patients with early primary open-angle glaucoma. We know that the main goal of glaucoma management is to lower the IOP into a target levels. The target intraocular pressure can be identified as the IOP level at which the sum of health-related quality of life from preserved vision and the health-related quality of life from not having treatment side effect is maximized. In practice, the target IOP includes the highest IOP level in a given eye at which no clinically apparent optic neuropathy is likely to occur. Setting target IOP is a multifactorial process, but recently it didn't depend only on central corneal thickness, but the corneal biomechanical properties have a significant role. So we aimed at our study to use the corneal hysteresis and corneal resistance factor in target intraocular pressure estimation in patients with early primary open-angle glaucoma. We ran a prospective quasi-experimental study comparing two groups, primary open-angle glaucoma group with early glaucoma, either perimetric or pre-perimetric, compared to normal healthy individuals. Patients older than 40 years that are newly diagnosed and not treated yet are included in the study, while patients having other types of glaucoma or in regular treatment or having previous ocular surgeries or aphakic are excluded. The target intraocular pressure was estimated according to the European Glaucoma Society guidelines and achieved either by monotherapy of travoprost or dual therapy of combination of travoprost and temolol. All patients have undergone a full history taking and comprehensive ophthalmic examination. At a visual field sensitivity was tested using Humphrey field analyzer. Ocular response analyzer J3 was used to measure Goldman intraocular pressure, corneal compensated intraocular pressure, corneal hysteresis, and corneal resistance factor. A spectral domain OCT was used to assess a peripapillary retinal nerve fiber layer and optic nerve head analysis. The statistical analysis involved comparison of glaucoma patients with controlled at baseline and after 4 weeks of lowering IOP by medications. Also, ocular response analyzer parameters of glaucoma patients were compared to each other before and after treatment. The mean target IOP in our glaucoma patients was 15.50. For glaucoma patients, this table showed a significant reduction in the IOP down to its target level by our medical therapy. At these target levels, we note that the corneal hysteresis increased after treatment, while corneal resistant factor decreased after treatment. Also, we note that at baseline, the corneal resistant factor was higher than the corneal hysteresis, while after treatment, the corneal hysteresis became increased and became more than the corneal resistant factor. When compared to control, we find a significant differences in all ORA parameters between glaucoma patients and controls. The challenging findings that the glaucoma lower the corneal biomechanical properties than control. We note here that the corneal hysteresis and corneal resistant factors after management are still significantly lower than that of control. This means that glaucoma lowers corneal biomechanics. These scatters showed the correlation between corneal biomechanics and intraocular pressure. We note that corneal hysteresis have a negative correlation with intraocular pressure, either Goldman or corneal compensated, all the time, even with controlled group, while the corneal resistant factor have a positive correlation at baseline after target IOP achievement and among control. The challenge is the correlation between the corneal hysteresis and the corneal resistant factor. At baseline, when we have an elevated intraocular pressure, there is a negative correlation between the corneal hysteresis and corneal resistant factor that changed up to a positive correlation after achieving target IOP, and this mimics the normal situation in the normal group. Some data patients, we find here that at elevated IOP, the corneal hysteresis is lower than corneal resistant factor, while after management and the drop of intraocular pressure, the corneal hysteresis became more than the corneal resistant factor. Another patient, we have an elevated intraocular pressure, very low corneal hysteresis and high corneal resistant factor, and this is reversed after management. As our study enrolled only patients with primary open-angle glaucoma, we recommend further research to evaluate the role of corneal biomechanics in controlling, assessing target intraocular pressure in other types and stages of glaucoma. Also, we recommend a long-term follow-up to assess the stability of corneal biomechanics with intraocular pressure control. So we can depend in practice on the directly proportional correlation between corneal hysteresis and corneal resistant factor in determining the target intraocular pressure level at which corneal hysteresis became higher than corneal resistant factor. Accordingly, ocular response analyzer is a very simple method to assess corneal biomechanics and estimate target intraocular pressure. Rapid procedure can guide us in the assessment of the effectiveness of our medications. If you want to remember one thing out of this presentation, just keep in mind to make the corneal hysteresis more than the corneal resistant factor by your medications or surgical intervention, and then you will achieve your target IOP levels. Thank you very much.
شكرا دكتور معتز، محاضرة جميلة ومتشكر جدا.
Thank you very much, Dr. Mu'taz. Now moving to Dr. Mahmoud Ismail, who will talk about dermatocele, a new clinical aspect approach.
Professor Dr. Mahmoud Ismail, one of the eminence in corneal surgery maybe in Egypt and in Africa and in the Middle East. Welcome, Dr. Mahmoud.
Thank you very much, Doctor. First of all, we would like to thank the Omani Ophthalmological Society for allowing us to share with them this meeting, and as a board member of the Egyptian Society of Ophthalmology, we would like to invite you the next year when everything is calming down in this world. Actually, when we see a case of desmetocele, suddenly we panic. We don't know what to do. First of all, we don't know what's the role of this infection, or it's a melting, or it just is a continuous pathology of autoimmune disease. When we see a case like this, in this case, we see a peripheral desmetocele, we don't know what to do. Well, whether to take him to surgery to make an urgent PKP or to continue his medical treatment in an attempt to have a smooth cornea and a competent cornea for suturing later on. And this is a dilemma, actually. And if we have a rheumatoid patient, we are always reluctant to do surgery for it. And however, until you have the perforation and complete melting, you have to go to take the patient for the theater and make a tectonic graft for this patient, allowing a complete anterior vitrectomy to all the lens matter and everything in the vitreous entangled, like you see in a case like this. But if you have to keep it very clean, even if there is some kind of bleeding. If you have this kind of defect, you have to fashion a tectonic graft. You cannot rely on a tectonic graft with a special terrifying. When you have an iris incarceration with a clean wound, you have the pleasure to make very good and rounded terrifination with a small terrifying. Every corneal surgeon has a small terrifying of 5 millimeters in order to face a problem like this. This is a case of leucophthalmos, and you indulge yourself by making a very clean cut, and you suture, and this is the post-operative, as you can see, looks quite accepting. So everything was so long like this. We face the case of desmetocele. We are not sure what to do. Sometimes we go for medical treatment. Sometimes we hurry with the patient for surgery to make the tectonic graft. Until Dua had made his landmark and defined what's kind of posterior lamellae of the stroma, a condensated layer that it's now called Dua layer. We met with Dua several times, and of course, we have faced the problem of having a case of bulk that we are not sure that this is Desmet's membrane or not. I confess to Dua that I have learned bulk from the original author who did it, which is Muhammad Anwar, and we never thought that there is another layer. But once we see a case of desmetocele, I always thought that there is a layer in front of the desmetocele in some of these cases. So taking the information from the classification of type 1 and type 2, there is difference between any kind of desmetocele. They are not all the same. Some of them are desmetocele and some of them are pre-desmetic decele. And this is the idea of this presentation. The desmetocele, you can even dissect the stroma from it and you can put a new cornea, and Dr. Hasbi have disclaimed it. But if you see a rough layer like this, and this even with infectious keratitis, this is not a desmetic layer. This is a pre-desmetic layer. And with medical treatment, you can succeed to have the patient calm and cool and improving until you have a sound cornea suitable for another procedure. So this is the pre-desmetic layer. How can we conclude that this is a pre-desmetic seal and it is safe to keep the patient on medical treatment? The only way I find for myself not only the clinical aspect, because sometimes you are not 100% sure, but the anterior segment OCT, you will find a layer of this pre-desmatic layer, which is the dual layer. However, even if it's very tiny and small, this is a desmatic seal and it can rupture anytime, and this patient should go to surgery as soon as possible. In spite it looks very calm and cool, because the descemet membrane is burred and we have no cover for it. So we have a differentiation now, a pre-desmatic seal and a desmatic seal. In infectious keratitis cases, there is the pre-desmatic seal. However, in autoimmune cases, it's in dry eye, it's a desmatic seal. Usually it's glistening in cases of pre-desmatic seal, or DOA seal as I call it. It's rough surface. Of course, it's more resistant in cases of pre-desmatic seal, and it's easier rupture if the descemet membrane is burred. The only way to be sure is the OCT. We will have epithelium cover in the pre-desmatic seal in cases of a DOA seal, and there is no epithelium in cases of descetic seal. Usually it's minute or not bulging, but in cases of the descetic seal, always bulging. I have finished my presentation, and I would like to share with you a very strange experience. We have been always refining the cornea, but now with the femto laser, you can have a new cut, which is called the decagon, the 10 surface cut. It fits like a puzzle inside the eye, and it's easy to make suturing for it. It's a new technique, a new aspect, a new horizon. We will see in the future how it will work. Thank you very much once again, and hope to see you in Cairo soon.
Thank you very much, Dr. Mahmoud, for the informative, nice lecture. Thanks on behalf of the Muscat of International Ophthalmic Society. We thank the Egyptian Society for their nice and informative talks, and hope to see you soon in
Cairo soon. We would love to have you in Cairo soon.
Sure, inshallah.
إن شاء الله ربنا يشيل الغمة إن شاء الله.
يعني نتمنى يكون المؤتمر الجاي
anywhere but physical hoping to see.
إن شاء الله.
دكتور أحمد، سيادة العميد هيقول حاجة. سيادة العميد اتفضل.
الله يكون يعني نتمنى يكون نلحق ان يكون مؤتمر الجمعية الرمضانية المصرية.
يا رب يا رب. أوعدك يا دكتور أحمد إن أول ما هننسق سوا، أنا الدكتور أحمد غنيم هو عميد كلية طب طنطا، وإن شاء الله إحنا سويا بإذن الله هنعزم حضرتك والدكتور راشد بإذن الله، نشوفكم في القاهرة بإذن الله.
بإذن الله. شكرا خالص الشكر للجمعية الرمضانية العمانية، وتحياتي بالنيابة عني ودكتور محمود إسماعيل كأعضاء الجمعية وعن السبيكرز. نشكر حضراتكم، ونشكر دكتور حاتم عمار ودكتور معتز، دكتور هشام حسبي ودكتور أحمد عساف افتقدناه النهارده، وطبعا تحياتي أنا ودكتور محمود إسماعيل لجميع
دكتور إبراهيم عدوي زميلنا برضه.
دكتور إبراهيم العدوي فين؟ أنا مش شايفه الشاشة.
أهو موجود على الطرف.
دكتور إبراهيم عضو مجلس إدارة وسكرتير سابق للجمعية ونائب رئيس مجلس الإدارة. بنرحب بحضرتك.
وعمنا واستاذنا كلنا، ربنا يديله الصحه.
كل التقدير والاحترام.
ان شاء الله باذن الله تعالى ان شاء الله.
شكرا جزيلا.
شكرا.
تصبحوا على خير. شكرا.